Welcome back, everybody. At this point, we have gone over the nursing assessment of the GI system, including common clinical manifestations of GI system dysfunction. So now we're going to discuss diagnostic assessment of GI function. Again, page number 646 in the book has a table of diagnostic information, which is pretty helpful. So, diagnostic assessment of GI function, specifically radiology. Here we're talking about like the upper GI series, which is a radiographic examination with fluoroscopy. This is done to locate obstruction, ulceration, or growths in the esophagus, stomach, and duodenum. We're really looking for GERD, peptic ulcers, cancer, or any other abnormalities. Patient generally will need to drink a contrast medium and is placed in various positions on the X-ray table in order to take pictures of all the different bits and pieces that they need to in there. A barium enema looks at the lower GI tract through radiology. It's going to be an examination of the colon using fluoroscopy to locate tumors, obstructions, and ulceration. Radiopaque substance is instilled into the colon via enema, hence the name. Let's see. CT, abdominal CT can be done with or without contrast dye. This is going to be used to visualize soft tissue and density changes when an ultrasound is inconclusive. Generally, they'll try an ultrasound before they jump straight into abdominal CT, which we'll go over in a second. Let's see. This is going to help detect tumors, abscesses, trauma, cysts, inflammation, and potentially bleeding. Radiography is combined with computer techniques to provide a series of sectional pictures of the gallbladder, intestines, and other abdominal structures. And then MRI, again, can be with or without some contrast. This is used to evaluate abnormalities generally in the liver or other abdominal structures. It places the patient in a magnetic field and uses radio frequency signals to determine how the hydrogen atoms behave within the magnetic field. It's pretty cool. It provides a better contrast than CT between normal tissue and pathologic tissue. Administration of IV contrast may be used to provide better imaging as well. So, ultrasound, there's a cool little picture for you. Again, this is going to be to obtain images of soft tissue, which may indicate any density changes, specifically looking to diagnose gallstones, tumors, cysts, or abscesses. Sonograms are produced with high-frequency sound waves, which pass through the body, and then the echoes vary with tissue density. So that's usually what you'll see. It's less invasive than like an endo, but not always very definitive. So usually it's a place to start in most places when looking at assessment of GI function. So next we're going to talk about nuclear imaging scans. In general, they can be hepatobiliary, which is used to determine bile flow distribution in the liver, the biliary tree, the gallbladder, and the proximal small bowel. Can confirm acute cholecystitis. A dye is injected, the patient is positioned under the imaging camera, and images are taken as the radioactive material is distributed. GI scan is going to be used to determine the site of any active GI bleeding, used primarily for lower GI bleeding. Radioactive tracer is administered IV and attaches to red blood cells. So images of the abdomen are obtained at intermittent intervals, and generally you will be able to see where, if and where, bleeding is occurring. Endoscope, I can't even say that today. I'm sorry, guys. EGD, so I'm not even going to attempt that word. It looks at the esophagus, the stomach, and the duodenum, specifically for tumors, ulceration, and any sites of bleeding or obstruction. Interventions to obtain specimens or treat sites of bleeding can be done at the same time as the diagnostic procedure, so it's a really useful procedure. An ERCP will help identify obstruction and other pathologic conditions in the biliary and common ducts. It can also be used to remove stones, to place a stent, or to facilitate any bile drainage. Endoscope is passed through the mouth into the duodenum with the use of fluoroscopy. A cannula is then positioned in the common bile duct and a contrast medium is injected. Radiographs are taken at that point, and if an instruction is found, interventional procedures may be performed. So it's a pretty cool thing. We don't do them at my hospital. If we have somebody admitted at Brattleboro who needs this, we will generally send them to Dartmouth, and then they come right back after this. So it's the fluoroscopy part that is hard for us in our itty-bitty hospital. So these are considered procedures. So as far as pre-op, in general, most people are going to be NPO for 8 hours before the procedure. So make sure that you're ensuring that. Verify the presence of any signed informed consent before the procedure. That is an important nursing job. Explain what they will experience during the test and after. Make sure we're doing our post-op education then for them. And make sure that they have an IV in place. There is nothing worse than sending your patient to endo with a junk IV. Everyone will always be mad at you for that, so make sure they have a good one. Post-op considerations. Generally, this person is going to need to be NPO until their gag reflex has returned. So not me. Generally, they're going to be passing a tube through the esophagus into the stomach to be looking at things. So what they do is they numb the back of the throat to take away that gag reflex so someone can tolerate the tube going down their throat. So once that is done, we really can't give them anything by mouth until that gag reflex has returned, because the gag reflex is a protective measure. It helps us protect their airway. So we don't want to be giving anybody food if they can't gag and protect their own airway, right? We're going to be taking vital signs every 15 to 30 minutes, whatever is the order. And really important thing is to monitor for perforation. We're going to be watching their temperature, make sure that's not rising. Their pain should not be getting worse, and we'll be keeping a very close eye on their vital signs as well. Other types of I can't even say endoscopic, we'll just say that because that's how I can pronounce it today. Studies are going to include flexible sigmoidoscopy. So this will help examine the lining of the rectum and the sigmoid colon to detect polyps, tumors, obstruction, or ulceration. The patient is going to be placed in a knee to chest position, often on a very special table. The scope is going to be introduced through the anus. Biopsies are taken from areas of suspect tissues. Also, polyps can be removed during this procedure. The patient will experience some cramping during the procedure, but generally they're going to be nice and sleepy, so it'll be okay. As far as pre-op goes, make sure that we're giving them any bowel preparation medications the evening before or as prescribed. Give clear liquids for dinner the night before. Generally, the person will need to be kept NPO after midnight until after the examination. And then explain what they will experience. Again, that they might have some cramping, but hopefully they'll be nice and sleepy and won't remember much of it. Post-op, we're going to encourage the use of deep breathing and relaxation techniques to help decrease their cramping. Observe for rectal bleeding after biopsies or polyp removal especially. As far as colonoscopy, probably all of us have heard of this word, colonoscopy, I hope. This is to directly view the lining of the colon with a flexible endoscope. The patient is going to be moderately sedated for this procedure. It can take between 30 minutes to an hour depending on the person performing it and the person receiving it. Polyps and biopsies can also be taken during this procedure. Pre-op, generally going to be to give clear liquids for 1 to 3 days before the test, so nobody likes to colonoscopy prep. And then the patient will be kept NPO for 8 hours before the test. So again, in the hospital, this usually is, NPO after midnight. As nurses, we're going to give bowel prep as ordered. That will usually include, some sort of potential suppository, potential enema, or potential laxative. Most commonly is going to be something called Go Lightly. So whoever developed it has a very fine sense of humor because no one actually goes very lightly when they take it. Anyone who's had it probably knows exactly what I mean. My favorite analogy is to say, after, I think on the instructions it says, after taking Go Lightly, you may, a watery bowel movement may result. And that's kind of like saying after you jump off the roof, contact with the ground may result. Take it for what it's worth. So again, explain the procedure, what they will experience. Might be a little bit uncomfortable, but they're mostly going to be sleepy and probably won't remember much of it, so that's okay. Once they come back post-op, we're going to verify the presence. For pre-op, we're going to be verifying the presence of any signed informed consent for the procedure. We always need to get informed consent. And then after the procedure, we're going to observe for rectal bleeding, signs of perforation. So again, fever, abdominal distension, pain, and keeping a close eye on their vital signs as well. And now, just because I know you're all dying to see it, we're going to watch. It's not going to let me. Okay, well, you'll have to watch this video on your own because it's age restricted. It's just a colonoscopy. Well, that stinks. It wasn't like this when I looked at it earlier. Anyways, this is a colonoscopy. Again, if you don't really need to watch it or want to watch it, you don't have to. It's a healthy colon versus polyp removal in an unhealthy colon. So it's a normal colon until about minute 8. And then you'll be able to see some polyps and how they're removed. So it's a good video. I'm sorry we can't watch it. Makes me sad. I spent a lot of time looking for it too, so hopefully somebody watches it. As far as diagnostic assessments to do with lab tests, so we can do testing of the stool. Fecal analysis is going to be basically a stool examination. We're going to be looking at the shape, odor, color, consistency, and then the specimen is going to be analyzed for the presence of mucus and fat. The stool specimen is obtained in a clear container, can be a bedpan or a container in the commode, and then sent for testing. Guaiac is something you're probably going to hear fairly often, or a occult blood test. This basically just tests for blood. It can be used as a colon cancer screening tool, and it can be used to detect really very small amounts of blood as well. So, sometimes it's really obvious that someone is having some bleeding in their stool. Other times you have no idea. So Guaiac is a really useful tool. Let's see. Stool culture, examining stool microscopically for the presence of any bacteria, virus, fungus, or parasites. Again, it's going to be placed in a clean container and sent to the laboratory for testing. That's nothing we can do on the floor. Sometimes you can do like a guaiac on the floor, not a stool culture. That's all I really need to say about stool cultures. There are a bunch of laboratory testing that's listed in the notes section of this. Be a little bit familiar with some of it. I'm not going to go into huge detail on everything because it is a lot of information. For me, you don't need to know the normal values, just know kind of what they're looking for in general, what they might be indicative of. And I think that will be fun. So here's all the list. So serum bilirubin, liver enzymes, ammonia, GGT, total protein, albumin, prothrombin time, PTT, activated PTT, and the H. pylori antibody test. I will go into a little bit of some of these, but again, not a huge amount of detail. Specific ones I want to talk about are the ALT, the AST, and the ALP. These are liver function tests. So really they can help us determine if someone is having some active liver disease. So they are important. Most of the time you'll see those abbreviations there, but again, be familiar with the whole word. So if you see it, you at least know in your head that it's talking about liver function testing. Ammonia is a product of protein metabolism. We might test for this in order to support a diagnosis of severe liver disease with encephalopathy, which we're going to talk about later. What else do I want to talk about here? Albumin is going to be another one. We might do this test to look for the altered protein metabolism. We'll talk a little bit about albumin, I think, later on. And then all like your clotting things, so the PTT, APTT, and PTINR are all going to be talking about clotting because, again, the liver is responsible for some clotting factors. So just, again, when you see those ones, be familiar that it might have to do with liver as well. So not all INR stuff is talking about Coumadin levels. It might also be reflective of liver disease. And the last one I did want to talk about is the H. pylori antibody test. This will help detect antibodies to H. pylori bacterium in the stomach. H. pylori is a risk factor for gastric endoduodenal ulcers as well as chronic gastritis or ulcerative esophagitis. So we're going to talk about that a little bit more, but be aware that H. pylori does exist. We'll go into some detail. Moving on. Nursing diagnoses, a whole bunch of fun stuff for you. These are some common nursing diagnoses. I plugged them in here, and I hope that you will be able to kind of look at these and start thinking about nursing interventions. I know we talk about nursing diagnoses and nursing interventions kind of abstractly, because that's kind of conceptual as far as a lot of disease processes go. I'm not going to outline every single intervention for every single disease process because you're in your third semester at this point, so some of this should be starting to make sense. But when you're seeing disease processes, when you see them, be starting to think of like nursing diagnoses, be starting to think of interventions that you can help a person with. So some that you might be thinking of as far as diagnoses might be these ones listed here. Of course, there are probably 1,000 other ones. But fluid volume deficit due to nausea and vomiting or diarrhea, altered nutrition due to anorexia, nausea and vomiting, diarrhea due to intestinal infection or inflammation, constipation due to side effects of medication, a loss of ability to initiate defecation or an improper diet, incontinence, fecal incontinence due to lack of rectal sphincter control, and limited coping ability due to inability to handle excessive stress. So again, I'm not going to go into interventions on those, but be familiar with those diagnoses and be thinking in your brain if you saw somebody who had diarrhea, you might be thinking in your head they're at risk for dehydration. What does that actually mean as a nurse? Our nursing diagnosis would be fluid volume deficit. So what are we going to do for interventions for that? Just start thinking in that direction. That will get you pretty far in nursing school, I think. So some common GI therapies that you might be seeing as nurses. The first one is going to be TPN, or total parenteral nutrition. As the name implies, this is total nutrition. This is going to be indicated when a patient cannot ingest, digest, or absorb nutrients, basically by taking food in orally. The exact order is going to be something that is, the exact formula will be ordered by a provider, and then pharmacy will generally have to mix it. So you can add, additional electrolytes or whatever you want into it. Must use a central line. So that is really important to know. TPN is really caustic to small veins, so it's not something we want to administer through an IV in the hand. This person must have a central line. It can be a PICC line, it can be a port, it can be a central line, up closer to their neck, but it has to be a central line. It will also be at a prescribed rate, and that is really, really important to follow. And you have to have an IV pump for it as well. Nursing care is going to include assisting with any insertion of the IV central line if they don't already have one, changing the tubing with each new bag or bottle. Sometimes they don't come in a bag, sometimes they'll come in a bottle, TPN. That bag or bottle and tubing needs to be changed within every 24 hours. The nurse might change the dressing and then removing the tubing when TPN therapy is discontinued. Really important to remember to do that part as well. Day-to-day care is going to include monitoring vital signs, glucose levels, and fluid and electrolyte balance. Generally, the patient is going to need to be weighed every day. Frequent mouth care should be provided, as they're not likely to be taking much, if anything, orally. The rate of TPN is slowly decreased to gradually lower the dextrose load before TPN is discontinued, and that goes back to why we were checking blood glucose levels, because it does have sugar in it. So we want to be making sure we don't have anybody who's got, their blood sugar is not like 300 because we're giving them TPN all of a sudden. And then the same thing, only a little different, is PPN. This is peripheral parenteral nutrition. Again, and all in the name, it's peripheral. It can be given through a peripheral IV, so it's different than TPN. It's got a different formula. It's less caustic to veins, so it can be given, through an IV in the hand or something like that. So generally we'll see this if a patient can swallow and eat, but is not able to take in enough nourishment to meet their body's requirements. It's really given to supplement a diet. Glucose content is going to be no more than 10%, which is not enough to supply the caloric needs of the body. So in an effort to increase calories, lipids will usually also be given separately. So at my hospital, it's always administered at 5 p.m. I don't know why. That's just when they write the orders for lipids to be administered, regardless of the person. They'll be on PPN, and then they'll also have a lipid order set that comes in at 5 p.m. I don't know why. So this is going to be the protein in the form of amino acids, vitamins, and trace minerals. They can also add more in through the pharmacy. So again, if someone needs some extra potassium or calcium, pharmacy can add that in. Let's see. IV site does need to be monitored carefully to ensure that the components of the PPN have not caused inflammation. Infiltration, if it occurs, can cause soft tissue injury. So we want to be making sure, while this can be given, peripherally, ideally it would be through a central line or something like that. But we want to be making sure we're really doing a lot to assess that IV site and make sure it's a good vein, make sure it's a good IV site, because if the catheter comes out and we get PPN underneath this, like in the subcutaneous tissue, it can be really damaging. That's enough about that. So here are some common enteral feedings. So if a patient has a long-term difficulty taking foods in orally, if they're in a coma or with dysphagia from a stroke, enteral feeding is indicated. So this means really that a person can still digest food, they just can't swallow it necessarily. So on the screen here we have a couple different ones. We have the nasogastric tube, which of course is passed from the nose to the stomach. A weighted tube can be passed from the nose to the duodenum or the jejunum. A gastrostomy tube is introduced through a temporary or permanent opening on the abdominal wall, which we call a stoma, and that goes straight into the stomach. And a jejunostomy, that's a nice word, is passed through a stoma directly into the jejunum. So we have a fun video here about NG tubes. This guy actually puts one in himself, so I think it's worth watching. But just a little bit of a recap here before he does this. NG tube or nasoduodenal tube will generally be used initially if they're trying to determine if someone is a good candidate for something like a G tube. Doing an NG tube first doesn't require surgery, fairly simple procedure, can be a good way to determine if someone's going to actually benefit from something more invasive. Important to note that these tubes can easily be misplaced into the trachea, especially if a patient has a decreased level of consciousness. They really need to be able to follow directions. As you'll see, this guy is going to drink a lot of water. He's just trying to get that NG tube down into his belly. So if someone has dysphagia or something like that and you're inserting an NG tube, fluoroscopy might be indicated in order to ensure correct placement. So placement of an NG tube may be done, I don't know what I was trying to get at there. So what I'm trying to say is you can check placement of an NG tube by a pH test or a swish test. Which is where they insert some air and you can kind of hear the noise. But this is really going to be per facility protocol and policy, so make sure you brush up on that wherever you end up. Definitive placement really needs to be confirmed by x-ray, and especially before starting feedings. So in the hospital, if we're doing an NG tube for something like bowel decompression, we can insert an NG tube, we can hear the swish sound and pull a pH, and we can then usually put it on suction. But if we're going to be instilling anything in there, we really, really, really want to make sure that it's in the stomach and not a lung or something else. I saw one really awesome picture, which I don't have here, where somebody was in a really bad motor vehicle accident and their face was basically traumatized, and they entered inserted an NG tube, but instead of it going into the belly or the lung, it actually coiled up in their brain. So we really, really, really want to make sure we know where this tube is going, okay? Once that initial placement has been confirmed, we will mark, we'll put a mark on the tube at the nares, and hopefully that will stay there forever. It will be checked per shift to make sure that the tube has not slipped out of place before a feeding is begun. Feedings can be given at specified times throughout the day in a continuous basis, or bolus, which we'll go over a little bit. If continuous tube feedings are ordered, they are administered with a feeding pump. Make sure that we are assessing the abdomen for distension. We want to make sure somebody has positive bowel sounds prior to removing it. We want to make sure, they had this NG tube, did it do what it was supposed to before we're taking it out, because the last thing you want is to take it out and then have to put it right back in. So we'll watch this guy really quickly insert an NG tube on himself. He is way braver than I am.
Hi, my name is George, and what we're going to be doing is shooting a video today on nasogastric tube insertion. And I'm surrounded by a bunch of my friends, and I've got an assistant named Tyson. He's going to help me with the insertion. So normally I would probably put in a 14 to 16 gauge or even an 18 French gauge nasogastric tube into a patient, but today, since the patient's going to be me, I'm going to place in a 14 gauge tube. So the tube's your typical sump style nasogastric tube, has an anti-reflux valve, has your suction valve with an adapter. First thing I'm going to do though is I'm going to take the anti-reflux valve off, and I'm going to attach the sump channel to the 5-in-1 adapter that comes with the tube. And now I'm going to size the tube to my length. So what you've seen in a lot of videos out there, including some of my own, we'll size it from the tip of the nose to the earlobe to the xiphoid process. So I'm going to put that proximal end down there, distal end to my tip of my nose, to my earlobe, and then carry it down to my, I don't want to make it too long, right, to my xiphoid process. So the mark is roughly about 57 centimeters, because we've got distant markings on this NG tube. So I'm going to take the Sharpie marker, just so when I'm inserting it, I can see where that 57 is fairly easily. And hopefully, it's a dry erase marker, or not a dry erase, it's a permanent marker, so it shouldn't come off on my nose either. So that's pretty obvious, right? I don't need to tape it. Cap that off. Now, instead of pouring the solution into a glass, I've just got this container right over here that has a nice chocolatey substance in it, which I'm going to use to sip and swallow while I advance the tube. So what I want to do now is I want to take the tube, make the preform bend in it, so it's a little bit easier to get past that nasal cavity and nasopharynx and progress to the oral pharynx. Tyson, you want to draw back about 10 cc's of gas in there? Yeah, and just leave it on the table. So I've done the preformed bend. So what I'm going to do now is lubricate the distal end. Now I haven't looked inside a mirror, etc., to see which nostril is better. I'm kind of going by which one has the least amount of air resistance. So I'm going to go with my right nostril, because I'm right-handed. It'll be that much easier for me to put the tube in. So we'll get this lubed up nicely. Syringe is ready to go. Emesis basin's right over here. Larger emesis basin in case I need it. And we've got our tapes pre-made, etc. So I've got my bit of water there. Let's give her a go and see how this works. So maybe I should take my glasses off. And there's a good chance I might cry. Okay, so let's go for it. Straight back. Okay. So hold that. It's almost as good as it looks. Where's that mark?
You're like 6 centimeters out.
Seriously?
It's like right at the straw, so it's like right there.
Yeah.
There's the trademark George tier.
You got it.
Yeah, you're there.
Yay.
Okay, you want to take that on my nose?
Yeah. Just hang on to that.
Got it?
Yeah. Want me to double tape it or just? Okay. Are you sure? There you go.
Okay. Syringe. Let me put some more fluid down there. Inject. Will you listen if we had a stethoscope? Okay, pull back. Is everything coming?
Yes.
Pull her up. No, did you keep going?
Well, I can't. It's all the way.
Oh, well then clamp her up. Well, there we go.
Well, I was going to clamp it. Yeah.
Okay. So you can't put an NG tube into a patient, eh? Don't forget to assess tube placement. And also confirm the chest everywhere, yes. For discontinuance, big breath in, get them to hold their breath. After you've ensured the subchannel is clear and the eyelets are clear, untape the tube like so. Just clamp the end off, Tyson. And take the syringe off. Maybe we'll dispose of that syringe. Yeah. And then put that on there. And in a gentle motion, I'll take a big breath in and I'll pull the tube out. If you like this video, hit like it.
So he's great. I laughed very hard when watching that for the first time. I hope you guys did too. That's just a recap of NG tube insertion and removal. Okay. Hopefully, I don't think the rest of this lecture is going to be as exciting, but there you go.
Let me know any comments you might have.
All right. So we talked about NG tube. Next, we're going to talk about G, J, and PEG tubes. We have all the letters of the alphabet today. So again, NG tube can be used for short-term feedings if necessary, but if it's going to be long-term, a G tube or a J tube generally is going to need to be placed. So a G tube is introduced through, again, the temporary or permanent opening on the abdominal wall, which we call a stoma. G tube is going to be passed through stoma into the jejunum. Placement of feeding tubes other than into the stomach depends on the nutritional needs of the patient. It may also be indicated when a surgical procedure has altered their anatomy. Sometimes the feeding tube is placed in the jejunum either during a surgical procedure or percutaneously. So patients who require long-term nutritional support for problems such as an inability to swallow may undergo percutaneous endoscopic gastrostomy, which is a PEG. Feeding gastrostomy tube is placed endoscopically through the abdominal wall. Pretty cool. The patient will then receive enteral feedings via the gastrostomy tube. The tube is marked with indelible ink at the point of exit so that correct placement can be checked daily. The area is observed for signs of infection, cleansed daily with soap and water until healing is completed. Generally, a 4x4 gauze dressing is used over the outside in order to cover this area and collect any drainage while it's healing. It's important to note that adding a feeding when there is too much residual from the last feeding may cause regurgitation and aspiration, so make sure that you are checking for any residuals prior to starting a tube feed. That will usually be per hospital facility protocol. So different types of feedings, again, depend on the patient's nutritional status and their tube type. So continuous feeding will be when the total amount is going to be given over 24 hours. Usually we'll start very slow, like 15 milliliters per hour, and then work up. Ideally, a person can get what they need over 8 to 12 hours, so that they just need the pump overnight, which is really nice because they do need a pump for a continuous feeding, and it's clunky and weird. So better to just get it done overnight and not have to worry about it during the day. And intermittent feeding, the total amount of nutrition is going to be broken up and given over 20 to 60 minutes throughout the day. Can be given with gravity, probably more often than not going to be with a pump though. And then bolus is going to be the total amount of nutrition is going to be broken up. It's going to be given over 5 to 10 minutes, usually 4 to 6 times per day. It's usually going to be given via gravity. With all tube feeds, it's important to remember to flush before and after. Usually a free water flush will be ordered, so you will probably see that in there. I know if you haven't already done Sim with Krista, I think you will be doing Sim with Krista, and you'll be doing a little bit of G-tube stuff then, so I won't go into too much detail. Some nursing interventions, generally speaking, for enteral feedings. Ensure your tubes are working properly. We want to verify placement. Again, definitively, we need to do that via x-ray, especially before we're starting a feeding. Of course, that's for one, like an NG tube or something. If they have already verified placement because it was a surgical procedure, you don't have to get another x-ray. But always be checking your swish sound. You can check a pH, check your residual, all those things. Make sure that the tube is working properly and then it's in the right place. Ensure the proper feed. So you're going to verify your order, make sure the pump is working correctly. You want to make sure that you're changing your bag and tubing per your protocol, usually every 24 hours, and then irrigate it with free water per order. Monitor for aspiration. So we're going to keep the head of the bed elevated. That helps prevent any regurgitation from happening, which can help prevent aspiration. We're going to monitor lab values, make sure they're not starting any sort of electrolyte imbalance. Monitor for GI upset. Monitor INO, monitor their weight. Usually they should be gaining weight, or at least not losing weight. Again, we're going to flush before and after medications, and when clogged, follow your facility protocol as far as flushing and dealing with a clogged feeding tube. Ensure comfort. This is going to be mouth care. If it's an NG tube, making sure that their nose is as comfortable as possible, making sure that NG tube is really taped down good so it's not causing any friction in their nares because they can get an injury to their mucous membrane that way. Changing the tape when needed. As far as G-tubes, make sure that you're assessing the insertion site, changing the dressing as needed. Rotate that external bolster to clean it. It should be movable. Not should be movable. For J-tubes, assess insertion, change dressing as needed. And there really should be no residual, so make sure you're checking that residual, and then notify the doctor if there is one all of a sudden. So next we're going to talk about ostomies. Again, this is mostly a recap from 103, so I'm going to kind of fly through it. I want you to know that ostomies can be in different locations. So colostomy can be in the ascending, transverse, descending, or sigmoid colon, and an ileostomy will be obviously in the ileum somewhere. Biggest thing I want you to know is that colostomy, because it's farther down, is really going to have more to do with solid stool unless there is some sort of GI disturbance and that person is having diarrhea. But if they have a colostomy, that stool should be much more formed. For an ileostomy, it's higher up. Water hasn't been absorbed yet, so it's probably going to be a little bit more liquidy. It should be liquidy. So because it is so liquidy, it's still going to be containing some digestive enzymes, which can be really irritating to the skin. So skin protection is going to be very important for long-term management of especially of an ileostomy, but really of any ostomy. There are different types of ileostomies. The pouch ileostomy or continent ileostomy can help free the patient from the need to wear a collection device. This happens the surgeon will generally decide what type of ileostomy they're going to perform. But for a pouch ileostomy, a small segment of the ileum is going to be looped back on itself to form a pouch. Pressure from the accumulating feces closes the valve, preventing constant drainage through the stoma. So the patient will need to empty this pouch every 3 to 4 hours during the day, usually by inserting a catheter into the stoma. Not every patient is a good candidate for this, which is probably why some of you may have never heard of it before. They really have to have the ability for self-care. This is not something that they can not do. They have to be able to put a catheter in there and drain it themselves. Otherwise, they have a whole host of complications. I think that's all I want to say about just know that there are different types of ileostomies as well as types of colostomies. They can be temporary versus permanent. Sometimes somebody just has some colon cancer. They need to go in and take out a portion of the bowel, and in order to help that bowel rest, they give them a temporary ostomy, and it's usually reversed in like 6 to 8 weeks or so. Permanent, obviously, is permanent. Single-barreled versus double-barreled, don't get too bogged down with that. Just know some, especially transverse colostomies, maybe a loop colostomy, which is also referred to as the double-barrel colostomy. Usually it's reserved for when there are plans of reversing that colostomy. That's all I want to say about ostomies for right now, different types at least. Nursing care of the stoma. That is actually a very good looking stoma. That's what it should look like. In general, stomas should be a pink or a kind of beefy red. That means that they have a good blood supply to them and that they're healthy. That's what your intestines look like on the inside. So that should be what they kind of look like when they're on the outside. A dark purple, a black, or a dusky stoma should be reported. It means that there is something happening there. It's not getting good blood flow. So the surgeon, especially if it's a new ostomy, definitely needs to know about that. Slight bleeding is normal, especially first thing following a surgery to create an ostomy. But of course, we should report an increased or excessive bleeding. And then really once that ostomy is stable and has been there for a while, it shouldn't be bleeding anymore. So any bleeding after that should be reported to the patient's physician. Slight post-op edema is also normal. We're going to need to make sure that we are checking the size of an appliance because the stoma will generally shrink in a few weeks, so we need to make sure that that size is appropriate and stays appropriate. The best way to do this, especially when they're new, is just constant measuring of it. Every time you change it, just measure it. And then once they are established, if they are oval-shaped or odd-shaped at all, best bet is to make a template so that that person has it for the rest of their lives, and they can cut their appliance to the exact shape that it needs to be. That creation of a template takes a little bit of time in the beginning, but it's really, really helpful so that you don't end up with kind of, stool leaking onto the skin. As far as post-op output, there might not be a lot for like 2 to 4 days in a colostomy because there's probably no food in there to be digested. It takes a little bit of time for it to start moving down that far. Even with an ileostomy, it should still be continuous because it's so far up. Even fluid will start to kind of come out there. It just takes a longer time to get to the colostomy site as far as output. So briefly, output and appliance care. An ileostomy is liquid. It's really caustic to skin. So we should be draining that ostomy site 5 to 8 times per day. Usually people with an established ostomy know exactly when they need to do it. Usually best time to change an appliance itself is going to be in the morning, once before they have put anything in their mouth to eat or drink, because that, again, starts the whole peristalsis all over again. Peristalsis is generally its slowest after first waking up. So again, for ileostomies, we want to make sure we're emptying when they are 1/3 to halfway full with stool or gas. doesn't usually need any irrigation because it's so liquidy. And again, they may be continent depending on the type of surgery. For a sigmoid colostomy, it's going to be pretty formed stool. The passage of stool will be fairly regular, kind of like a normal person's bowel movement habits. Irrigation might be necessary in an effort to kind of get a regular evacuation schedule going. And then again, for appliance changing, make sure you're cleaning and protecting as much as possible. The book says change every 2 to 3 days or PRN. I mean, I have, as far as I'm concerned, if your ostomy appliance is sticking on there, don't mess with it, right? Because the worst thing you can do is take off an ostomy appliance that was sticking on there really good and highly functional and replace it with one that's not. So every 2 to 3 days or PRN. You'll kind of figure out what that means for going forward in your nursing life. So nursing interventions, assess, of course. We want to make sure we're assessing that stoma site, make sure it is pink or red, not dusky or purple or black. We're going to assess the output for amount, consistency, color, if they're passing excessive amounts of flatus. Check the abdomen. Is it tender, distended, soft? Check for pain. Do they feel very full? Do they feel constipated? And make sure you're assessing for bowel sounds as well. That peristomal skin, again, clean it and protect it. It should look really good. If that liquid stool or any stool has gotten anywhere on the skin, it might start to break it down. So make sure at all times you're cleaning and keeping that skin as intact as possible. As far as education, make sure you're including the physiology of the ostomy and the steps involved in taking care of the stoma and skin. For some people, knowing how it works really helps them process it. Other people don't want to hear about it. So, of course, assess their needs and go from there. Odor control is going to be a big one. That's something that a lot of people have concerns about when they first know that they're getting an ostomy. There will be odor. That's just the way it is. When the drainage pouch is changed or emptied, just as there is with a normal bowel movement. So good hygiene is going to be essential. Other measures include elimination from the diet of certain foods known to cause odor or gas, like eggs, fish, garlic, raw onions, cucumbers, things like that. Your book has a whole bunch of stuff. Eating too quickly and not chewing food can cause gas. Carbonated and alcoholic beverages can also contribute to gas. So make sure we're talking about that with people, right? So they know what to expect so that they can ultimately avoid any, embarrassment. Ostomies are a big part of embarrassment for a lot of people, and they don't need to be. I went over a little bit of diet. Last thing I want to say about diet for someone with a new ostomy is that they need to pretty slowly resume their regular diet. They shouldn't just jump back into it. All ostomy patients should be taught to prevent problems with diarrhea, constipation, and blockage. So dietary guidelines are going to be really important for anybody with an ostomy. Okay? And I think that's it. So you've survived all of the recordings for day 1, and then after this you're only going to have a fairly short pediatric GI lecture to watch before class. So thanks for sticking with me, and I'll see you guys next time.